Good afternoon. Thanks to the organizer for inviting me to this thrilling meeting. And we're talking about management and novel treatment approaches in mantle cell lymphoma. Sorry. In my set top 10, as you know, non-Hodgkin lymphoma as family of cancer represents the 7th most frequent tumors. But mantle cell lymphoma account about 6% of all non-Hodgkin lymphomas, predominantly in the elderly more than 60 and male patients. In advanced and early stage at diagnosis, extranodal involvement is frequent, bone marrow, gastrointestinal, liver, and spleen. We can divide in 3 categories: indolent, classical, and transformed. The indolent is about 15%, classical 80%. About the indolent form, that's good news. The possibility of use of ibrutinib 560 milligrams combined with the rituximab for 8 cycles and the maintenance with only ibrutinib for 2 years and the stop in patient with a sustained MRD negative. The primary endpoint of this study is published on 2022 was a complete remission after 12 cycles. This is the patient characteristics. I would like to underline the positive of SOX11 in over 65% of the population and obviously the low Ki67 in over 95% of patients. Very good results. After 1 year, 40 patients out of 50 were in complete remission, and these are the curves, really good in progression-free survival and overall survival. About the treatment in younger patients, less than 65 years, the statement is at the moment the autologous stem cell transplant in the first line in a complex of RHE up front. Also, the maintenance with rituximab, as shown in the study published by Guido in 2017 after 4 cycles of RDAP and the autologous bone marrow in first line, an advantage in terms of progression-free survival and overall survival. We are waiting for the Triangle phase 3 trial results will be present in the next ASH, and the role of autologous in first line and the role of ibrutinib in the upfront maintenance. So in conclusion, in this setting, the intensified protocols with RC is standard. Autologous transplant remains the standard outside the protocols. Maintenance with rituximab seems feasible and prolong survival. New target therapies to be integrated soon, in my opinion. The treatment in the elderly patients ineligible for transplant. We have this historical published on the Lancet 2013 by Rammel, 2 possible choice of therapy, R-CHOP or bendamustine rituximab. In the European way, we have developed the Benda platform with ibrutinib and cytarabine, and the RBAC in Italy by Phil 500 has shown a really good performance in terms of progression-free survival at 4 years, over 60%, and term of overall survival, over 70% at 4 years in the elderly patient. Also, in the long-term follow-up, RBAC a really good performance with 7 years progression-free survival, over 50%, and over the 60% in terms of overall survival. This recent study published on 2022 June by Michael Wine in the trial of SHINE trial, who performed the bendamustine rituximab for 6 cycles with maintenance and the consolidation with ibrutinib and rituximab, and the standard arm, the bendamustine rituximab and the rituximab as maintenance with the placebo. The results was the primary endpoint was met with significant improvement in median progression-free survival, 6.7 years in the group with the maintenance of ibrutinib against 4.4, and 25% of reduction of risk of progressive disease. But in terms of overall survival, the two groups not differs, probably because the group with the placebo was recovered by ibrutinib in second line. The treatment relapse setting, only a few words. You know that the time at the moment of relapse is really important. The late POD and the early POD has two outcomes completely different. And also the therapy in the early POD, less than 24 months, the ibrutinib is the only therapy at the moment could you used. In the late POD, you can try to use again the chemotherapy, RB, RBAC, if you didn't use before. But what happened when the BTK stopped to perform? The overall survival is really reduced with only 3 months of overall survival. But we have some good news with the possibility of use again of chemotherapy, the use of new agents such as venetoclax, but also pirtobrutinib, bispecific antibodies, and the CAR-T, and the ZUMA-2 is the trial who has shown the real efficacy of the CAR-T in this setting, also in terms of long-term follow-up. So in conclusion, the standard of care in young patients as a therapy with the cytarabine rituximab and the autologous in the first line with the maintenance of rituximab, but we are waiting for the triangle data. In the elderly, we can choose with the R-CHOP and the rituximab maintenance, or a schema with the RC and R-Benda, or you, not in Italy at the moment, you can choose for a maintenance with the ibrutinib after a bendamustine rituximab induction. But we have many questions for the future. The chemo-free treatment frontline is superior to our chemo? Maybe. If yes, which is the best free combo? And how to use new tools such as MRD, PET-CT, and NGS in daily practice? And can we predict the target therapy resistance? And so we have to answer to these questions. Thanks.